Thank you. This slide is to tell you that I don't know if you know, but during replication of the DNA, approximately 3 million base pair mistakes are made. And these mistakes are more commonly seen in areas of the DNA that have repetitive sequences. These are called the microsatellites. So very quickly, whoever designed the cell realized that without a robust mismatch repair system that will proofread the DNA before completing cell division, well, probably wouldn't be here right now. Now, next slide. Again, to tell you a little bit about the microsatellites, these are small sequences of DNA, usually 1 to 6 bases. They are all over the genome, and most of the microsatellites are in what we call non-coding regions. However, a few of them are part of genes that are very important to regulate proliferation and apoptosis, especially the transforming growth factor beta pathway. So next slide. Next slide, thank you. So the DNA mismatch repair products are proteins. The four most important of them are MLH1, PMS2, MSH2, and MSH6. And there are other ones, but are not as significant. Now, these proteins act as heterodimers. So MLH1 links with PMS2 and MSH2 links with MSH6. It's important to remember because of some of these staining patterns that we can have. So next slide. Thank you. So anytime that we have deficiencies in the mismatch repair system, now there you go, thank you. It could be related to two possible causes. One is the presence of mutations in the mismatch repair genes that code for those proteins that I just talked about. Or it could also be the result not of mutations in the DNA, but things that happen after replication has finished. And this is what we call epigenetic abnormalities. In any case, either by both problems, we get to a tumor that has microsatellite high instability. So there's two types of microsatellite unstable tumors.
Hello, my name is Gianni Jaroszkiewicz, a Senior House Officer at the Leicester Royal Infirmary. Welcome to this 5-minute presentation on cardiovascular disease caused by atherosclerosis. I will discuss the pathophysiology of atherosclerotic disease and risk factors which are important for understanding preventative measures, management and treatment strategies. The two latter topics will be covered in an additional presentation. Cardiovascular disease is a leading cause of death worldwide and covers a wide range of conditions, with atherosclerosis being implicated as a cause for the vast majority. The consequence of atherosclerotic plaque formation and/or rupture is by far the most common cause of cardiovascular disease, for example the acute coronary syndromes and also cerebrovascular disease from transient ischemic attacks to ischemic strokes. This diagram illustrates atherosclerotic development, which can be defined as a complex inflammatory process characterized by lipid and macrophage-rich plaque formation as a consequence of endothelial arterial wall injury. Many factors can damage the arterial lining, from sheer mechanical stresses, for example turbulent blood flow caused by hypertension or at sites of arterial bifurcations, to biochemical and immunological factors. Following endothelial damage, there is increased permeability of the vessel wall to plasma proteins, predominantly lipoproteins, into the intima. Macrophages then engulf the lipoproteins and form lipid-laden foam cells, which are seen as fatty streaks. With cytokine release and further migration and proliferation of macrophages and smooth muscle cells, a growing fibrolipid plaque forms. With plaque progression, any further damage to the lumen causes platelet aggregation and thrombus formation, and as blood pools into the ruptured plaque, it becomes unstable, growing in size to reduce vessel circumference. When the diameter of the lumen is halved, hemodynamically significant stenosis occurs, which causes ischemia with increased oxygen demand. Total occlusion results in infarction distally. Unstable plaques can also rupture and form emboli at distant sites. Atherosclerosis is inevitable as we age, and the pathological process occurs in all from early adult life. However, if we recognise the factors that contribute to its development, we can appreciate ways in which to slow progression. The main modifiable risk factors include hypertension, smoking, cholesterol, and diabetes, but of course the factors we cannot influence are increasing age, male gender, family history, and genetic composition. There are many causes of primary hyperlipidemias, which can be defined broadly according to the lipid derangement of combined hyperlipidemias, hypercholesterolemia, and hypertriglyceridemias. Non-specific physical manifestations may include xanthelasma. The most common form is familial combined hyperlipidemia, manifesting as high low-density lipoproteins and high triglyceride levels, causing suppression of high-density lipoproteins, leading to increased cardiovascular risk. Primary hypercholesterolemia is an autosomal dominant disorder which can be hetero or homozygous, with the latter presenting with ischemic heart disease in childhood and death occurring in adolescence. The defective gene causes underproduction of LDL cholesterol receptor in the liver, and pathological tendon xanthomas are seen. It is important to be aware of these conditions because understanding their etiology will help direct treatment. Prevention is better than cure, and therefore addressing modifiable risk factors is very important because progressive disease can be fatal if not grossly disabling. Patient education plays a huge part in this because their understanding of the health implications of their actions may help to influence lifestyle choices and hence reduce risk. Pharmacological interventions such as antihypertensives, antidiabetic medications and lipid-lowering therapy are of course valuable, but lifestyle modifications are often the first-line approach. Encouragement of a low salt, low saturated fat, healthy, well-balanced diet along with exercise can reduce blood pressure, cholesterol and blood sugars. Stopping smoking is one of the best health protective steps overall that patients can take. And specifically, smoking almost doubles the likelihood of having an MI compared to age-matched non-smokers because of the toxic nicotine, tobacco and carbon monoxide, which, as well as causing endothelial injury, increase strain on the heart through mediating adrenaline release. It has to be remembered that stopping smoking can be a very difficult task for patients, and where possible appropriate support should be offered, for example nicotine replacement. In summary, understanding how and why atherosclerosis develops is important in being able to reduce cardiovascular disease risk. For those that have already developed a significant degree of disease, addressing modifiable risk factors is still crucial, but pharmacological management and/or invasive therapies may be required to treat or at least manage cardiovascular disease caused by atherosclerosis.